addiction services in PEI. This evening we are presenting from PEI, traditional unceded territory of the Mi'kmaq. I'm Amanda Hudson and I'm the Director of Research for Mental Health and Addictions with Health PEI. I'm also on the advisory board for CRISM Quebec Atlantic. I will be joined by 4 co-presenters this evening, and I will let them provide their own introductions at the beginning of their presentations. When we first saw the CRISM call for proposals, we knew that we wanted to invite people who have had experience with addiction services on the island to help understand treatment barriers, to share knowledge of ongoing initiatives, and to consider new solutions that might meet the needs of our PEI community. Our 5 presenters have met on several occasions to discuss these points and to engage in mutual knowledge exchange, which has culminated in this evening's presentation. We know that addiction is a complex issue, and there are many epistemologies or ways of knowing that must be considered to fully understand the development and the treatment of addiction. Our event committee reflects this viewpoint, and it includes 2 experts with lived experience, an expert with clinical and lived experience, and 2 researchers with backgrounds in substance use and addictions. This evening's presentation will take place in 2 parts. First, we will have presentations that encompass evidence from experiential, clinical, and empirical lenses, and then we will finish with a facilitated discussion and time for questions and answers. To ensure we have time for the full presentation this evening, we'll ask that you please hold your questions until the end of the event when we invite questions and discussion. And before we begin with presentations, I would like to share that this session is being recorded, and we will stop the recording when we start with the discussion portion of the event. And just a couple of last housekeeping items. So if you could please mute yourself when you're not speaking, that would be much appreciated. If you do not wish to appear in the recording, you have the option to keep your video turned off. And when we begin the discussion time, we will accept questions both verbally as well as in the chat box. So we'll be keeping an eye on that. So please just do whatever you're most comfortable with. And with that, I will turn it over to our first presenter this evening, Ellen Taylor.
Hi, everyone. My name is Ellen Taylor, and I am a teacher from Canoe Cove PEI, and I'm going to share with you my experience and what led me to have a forum for information on addiction and mental health in our province, and what the 5 main things we decided that were the most prominent when we were talking to people. So my background is that I'm the youngest of 3 daughters, and I would say, like, good time growing up, nothing major happened. I was good to school, I played sports. I kind of always felt flawed is the only really way I feel that I can describe that feeling. I just never felt like I was quite either good enough or funny enough or smart enough. And it wasn't because anybody told me that. I just really didn't feel that way about myself. Whenever I had my first drink and up until when I had my last one, it was very out of control. But I did have some bouts where I stayed sober from alcohol and drugs, but I was doing engaging in my eating disorder. So it was kind of on the go at all times. I didn't see alcohol abused at home. I didn't even see alcohol used at home because my parents didn't drink. They, for their own reasons. My mom's father was an alcoholic, and it ran in my dad's family as well. So neither of them drank. So Christmas wasn't, anything, Christmas, birthdays, New Year's Eve, we just didn't see really any alcohol. There definitely wasn't any in the house. So that was kind of my experience, and I got into trouble, just normal stuff, I would say. And when I got to high school, it was getting to the point where when I drank, it was really volatile and abusive, and I didn't really, very unpredictable. So then very quickly did I realize that how much I loved alcohol, because it made me numb my feelings and feel better and feel for that time that I was somebody that I wasn't. And I just kind of went along that way, and I had friends tell me that, and a few of my family told me that, or didn't tell me, but just kind of said to be careful. And the idea in my head of an alcoholic, the stereotype. I was not that. I was like, I have a good family. I'm smart, you know, like I wasn't in any accidents or anything like that. And I thought, like, that's crazy. Like I could stop doing that. And then for those times too that I did stop, and then I was engaging in my eating disorder, but I thought, well, at least I didn't drink, so I can't be an alcoholic. They drink every day or every in the morning or whatever thing that I was making an excuse for. So I had a daughter when I was 20, graduated from high school when I was in university. So I had her. And for the first probably like 3 or 4 years, I really was more engaged in my eating disorder in my drinking because I had quite a bit of responsibility while like trying to study and look after a baby. So I didn't really, but again, like when I drank, it was out of control and it was like something would happen. At that point, it was starting to get like through those years, I was in car accidents, hit and run accidents. I was sexually assaulted. I was like letting people treat me like how I felt, which was like basically trash. Um, so when then she got older, I kind of started to be going out more and stuff like that. And it was around when I was, I'd say 27. Um, I was starting to really like lie a lot about my drinking, lie a lot and manipulate, and just kind of where the resourcefulness of addiction or of addicted people come in. I just was trying hard to keep everything under control, but it was very out of control. Um, so I remember I missed a family thing, or I got my parents to take my daughter, and my dad that night, he said, I'm pretty sure you're going to have a problem, you know, like that's going to give you a run for your money. And I was like, I don't think so. Like, I just kind of use it to treat my eating disorder. And then after that, like I drank at work and I just didn't, you know, that should have been enough. And that's why I say like it's cunning, baffling, and powerful. And we never know, because for a normal person, that would be enough if they got caught drinking at work and basically threatened to lose their job. And it didn't take one pep out of my step. I was just like, whatever, I can handle it. Or, you know, I'd manipulate or think I was invincible. And so I went back. So 2008, I got caught for impaired driving. And then when I went to Homewood for treatment. Sorry, I'm kind of going a bit backwards. I went there in 2009. And then I got back to university to take my teaching degree in French, and I got a DUI almost at the end, so in the middle of my second semester. And I woke up in Sleepy Hollow, that's our provincial jail, and I had no recollection of the night before. I didn't know if I killed somebody. I didn't know, you know, if something happened to me, or I didn't know if I like broke in somewhere, or like just, it was just so unpredictable what I would do. So anyway, they came and they said, you're arrested for impaired driving. And they told me that when I had to go do my fingerprints after, because I was like so incoherent the night before when they arrested me that I couldn't even, like, they just couldn't get me to do it. So I went the next day and there was a couple police officers kind of walking by and they were like, it's unheard of that you would still be alive, that your blood alcohol level was 0.34. Like that's 4 times over the limit. And I really was just like, okay, like they were trying to kind of say, you know, this is really bad. Like you need a big time, like kick in the butt basically. But so I ended up getting 75 days in jail for that. And that was so humiliating and terrible. And I can still remember I actually had to have a procedure done when I was there, and I had to walk through the QEH with shackles and handcuffs on. And again, like back to the how insidious this disease is, most people would be like, okay, maybe I shouldn't do that. But I just kept going. I just kept pushing down the issues and pushing down the pain. And I just went on my merry way, like, and it was just really awful. So got out of jail, went to a women's recovery home here on PEI, and got along great, was really good. I still wasn't really putting a whole lot of work in, but I was doing, what I had to do to stay there, like be sober, and, they have jobs for you to do and you go to a lot of meetings, and it was great. I had gotten married after that in 2015, so I'm jumping a little bit. So I finished my teaching degree, got a job again during at work. And like I was a first year teacher. I just think like I was a first year teacher and I was drinking at my work, at my job. Like it's just today I can't even, it boggles my mind that I did that because I just don't know how it was functioning. So I got married and married an alcoholic, or I mean, I guess I can't say he's an alcoholic. It was very toxic and abusive, and it was both of us. It wasn't just him, but it was just two sick people being together never ever works out. So I basically walked away from that. Another time, this is going back a little bit, sorry, 2018, I got caught drinking and driving again. And that was when I had like a little bit of a start to sobriety. And I was so devastated. I was like so suicidal. And my sister came over and I remember just laying on the floor in my garage. And I was like, I don't know what to do. Like, I don't know. And my dad said to me, he had to come and get me at the police station in Summerside. And he said, if you are trying to end your marriage, don't do it this way. And I think that was what I was doing subconsciously, even though it was hurting me way more than it was hurting him. But I think that I felt trapped and I didn't have any healthy boundaries, and I had to, this was kind of my way out. So anyway, I left the marriage. That was fine. Then kind of moving up till just a lot of that same thing didn't work. Went on sick leave, go back to work, something would happen, go on stress leave. Like it was just, yeah, very chaotic. So in the summer of 2019, so in July, I went to see my psychiatrist with my sister, and I told him that, well, basically she told him that, I had stolen medication from my brother-in-law, I had stole alcohol, I had stole other stuff, and she said, like, I think that she's just telling you things that, aren't the worst, but this is where I am at it. And she was like very angry, and we had such a like disconnected relationship in those days. So that day he said, I'm going to put in a referral for you to go off island for treatment. And I'm going to try to kind of have it fast tracked. And so really about 2 weeks later, they called me from Oak Hill Recovery Center in Nova Scotia. And it was a women's run place, and it was all women that worked there. And most of them were in recovery. And I just told them when I got there, I said, I will do anything you tell me to do. I will do anything. Like just, I have to get it this time. Like I just have to, because I can't put myself through that. I can't put my daughter through that. My family, I was just like, what do I need to do? And I did a lot of things that I didn't really think had much point, and I thought things were strict and different things like that, but it was just I was there to get better, and that's what I did. And there was no technology, and there was a lot of counseling and a lot of sharing of experiences, and it was just really an awesome experience. When I was leaving, so I stayed there for I think 9 weeks and came back to PEI. This will kind of lead into my next part. So when I was home, I was in Charlottetown, and there's a lot of AA meetings during the day, like downtown, that a lot of people go to, a lot of really good people in recovery go to, new people go to. It's just kind of a mixed bag of people. And I was at that meeting, and it was just a regular meeting, and a guy came in, and you could just tell like just the pain and the like desperation. And he was saying that he was on a wait list and he has nowhere to go. And it really, I don't know what it was. Like I've heard that before, and I've heard people say similar things, but it really like got to my heart. And I was thinking, I just felt so bad. And then he shared some other stuff. And then after that meeting, there was a few men who, again, like would be excellent, were talking to him. And, he seemed like, they were really encouraging him and giving them the phone numbers and stuff. And I just remember walking home and I'm like, I can't, this is so crazy that this is going on. And I felt like, if he goes home and kills himself, like we sort of like listened to the preview of that. And it just really, I just kind of got to thinking about like making connections and relationships in the program. And I'm so glad that he did that. But just that I find politicians sometimes they can sit at a desk or they can make rules or they can type policies or they can do this. But when you see a person right in front of you, I think it has such an impact, or it has the potential to have such an impact. Because what I said, I went on social media and I said, I wish the health minister or anybody that has money with the government, or you know what I'm saying, they said, I think that they should come to a meeting and see the people that are getting denied and seeing the people that are going to the hospital because they have nowhere to go or going to somewhere like that. And I posted it on Facebook and I had over 200 messages between Instagram and Facebook about people's experiences, their families' experiences, questions, like you name it. So I said, what can we do? So I had some people in mind that I knew would share their story or share their family story. And I had a forum at the Arts Guild here in Charlottetown. And there was 200 people, I think there. And so from all that kind of work, we had it February 11th. So like from January, we kind of planned for a month. So we had all this. So I looked over all my stuff and kind of identified 5 things that were really prominent to, okay, this is really affecting people. This one's something that like a lot of these people have encountered. So I'm just going to touch on those briefly. So the first thing was the idea that the different branches of government don't communicate with each other. For example, if you get out of jail, you don't have an addictions counselor. If your addictions counselor didn't know you were in jail and they close your file, you get out of jail and they're like, oh no, you're back on the waiting list. Like no one really communicates with each other. And with the housing, like there's just always seems like there's blips for people who are trying so hard to get well that they're still facing things where they have to fight. And like it doesn't work that way. Like they were taught, it's tiring. So that was the main one. And because it all, they should have it all kind of figured out before that happens, right? But it doesn't always work. Same with like social assistance or those kind of people, those kind of resources have to be available for those people because they have to take advantage of it because those are the ones who are, clogging up the healthcare system. And, it's just so preventable, in my opinion. So yeah, I was just saying if there was a one kind of place you could call or a department and say, this is what I'm not connected with mental health, I'm not connected with addictions, like what do I do? And if there was a one-stop kind of place where they could figure that out for you, or even just for you to say, could you get back to me? I'm looking for these resources. Could you let me know? That was a really big one. The second one was the lack of beds at detox. So here on PEI, we have 15, there's 15 beds, and 16 total, but there's 1 bed for kind of reserved for emergency admissions at the QEH. And for 140,000 people, I don't feel like it's a lot. And I think that's kind of been always an issue, to be honest, the lack of beds at detox. But anyways, so this kind of ties into the other one. So the lack of criteria, I'll say, about going off island for treatment. That was the third one. And I definitely don't think that there's nothing wrong with the program that's here. I think it's wonderful. I did it twice. When I went and it was all women. That was what I needed at the time. But like, it's just very much, some people will say you need a psychiatrist referral and a counselor referral. Some people are told, no, we're not sending anyone off file until June. Other people are told, okay, I'll put your, GP can put a referral in and you may get to go. So there's no real like process to it. And I think people get upset because they feel like they don't matter. And I'm so grateful that I got to go twice to off island treatment and the province paid for it. Like it will save my life, but and then people hear of other people going and, well, if he got to go, why don't I get to go? And there's just no real like procedure where checklist, okay, did they do this stuff? Have they tried this? Have they tried this? And then kind of make a plan. So that was something that, and then there was people thinking, well, you have to know somebody to get off island treatment. And I don't know, that wasn't the case, but it's just something that just another thing that people feel like they don't matter. Oh yes, so triaging for beds at detox. So I said that we have 16, so 15 because one's held for emergency. And so what is happening sometimes is that's another thing. There's kind of no rhyme or reason that it can be found anywhere. But so I may call Monday morning and say, whatever, I'm Ellen Taylor, this is what's going on. I need a bed. And they may say to me, okay, can you be here at 2 o'clock this afternoon? And then I go to a meeting that night and someone says, I'm going to Talbot House. Or no, like say, there's no beds at the recovery home, so I don't know what I'm doing. I'm like, well, or at detox, sorry. So I'm like, well, no, I'm going like before you, because that's what, and it just, there's no real connection between like how they triage them. And I mean, some people, a few people have said, their loved ones or their partners or grandparents or that, like, she said, like some people die waiting for a bed of detox because they're such a life and death situation for so many that people just, they're like, well, I'm not going to bother if I have to call tomorrow. I want to go now. I'm just going to drink or use and then, start the whole crazy cycle all over again. So yeah, we just have some people are told, it's a week wait. Some people are told Wednesday morning, come at 9 o'clock. Some people are told it just varies so much. And if there was, I'm sure there must be a rhyme or reason for it, but no one's ever said that. And I think if people know that, like, it's just another thing about not mattering. Like, well, how come Ellen's getting in before me? That's not fair. They told me, and then it just kind of, it gives an even more negative spin on addictions and mental illness that does not need to be there because we have to like deal with enough of that stuff. So that would be the fourth one. And the last one is the lack of programming at our provincial jail. So they don't have any programs really on the go. They used to have an AA meeting and possibly a SMART meeting, I'm not sure, but they have taken that out. And like when you think about it, there's not a whole lot of things to do in there. And like the fact that those people might go to a meeting and they might find someone in their community that, can be their sponsor or can be a friend or can be somebody that they can, depend on or call. And, instead we're just nothing's going on. And, it's unfortunate that all those people will really, you never know when it's going to work. Like you never know. It might not help one, it might not help 50 people, but it might help one. And then, that's worth it to me. I think that they need to have a more progressive kind of collaboration approach out there at just to kind of get all the case plan stuff intact before they go so they know, this is your worker here, this is your worker here, this is your worker here. They're expecting you this day. And so it's all kind of set out in front of them and it's, keeps them motivated because if you're leaving with nothing, you have no one to see and you're going to a men's shelter, like That's, you know, you're not going to call your counselor. Chances are pretty good. Yeah, so I had contacted the jail about the programming and I had 3 answers back, and it still doesn't specifically answer the question. So I know there's very minimal programming going on out there, because I've also talked to staff of there, and some of them have left and some of them have said it's just up to whoever's on. So it's not even really an expectation. Like if you feel like doing that, put a meeting on, or put, I don't know, the self-esteem workshop, but you know, the morale, I just feel like it's kind of hard to stay well anyway, but hard to stay well if you're coming from jail with no plan. Those are the 5. I did just want to talk about aftercare. When I was in Oak Hill, when I left, sorry, we did on Skype. We had a aftercare program and to stay connected, and you know, what are you doing for counseling, or what are you doing for self-care? What are you doing for your job, and how's your stress level and all that stuff. And it was really awesome because we got to make a recovery kind of plan, I guess, with like people's numbers, people's names, different resources on PEI. You know, if you get home and you're like, well, I don't think, you know, I think I might call the rape and sexual assault center because, you know, I still don't feel great about that. You know, that would be set up then. And when I came back here before COVID, we had like a peer group kind of thing. And there was, I think, about a dozen of us. And it was so awesome because it was more, you know, your living problems. And, you know, none of us were using or drinking, but, you know, stuff comes up with family and kids and money and those kind of things. And it was really, really wonderful. Like we're still in contact with all of them. So at the forum that I had 2 people come up to me and they didn't even know anything about the aftercare. They didn't know really. It was 2 guys, and they weren't familiar with it. And they're like, how do we like get it? I was like, well, I had it through, you know, Oak Hill, we set it up, and then that's just kind of how it worked. And they were like, well, how come, like, do you think we could join that group? And I'm like, well, I don't know. So it kind of sent them down a rabbit hole. And also I had no clue because I was like, well, I know how beneficial aftercare is and how beneficial it was for me. And the fact that you know, the province spent $40,000 sending these people to off-island treatment and they don't even have a recovery plan or aftercare. Like, it's an afterthought, and it's always kind of, you know, anything that will set us up for success in recovery, we need to do it, or we need to at least try it. So yeah, I just kind of comes back a little bit to be putting the onus on the person. And I get that, you know, they have to go seeking it, and I understand that totally, but the inconsistency of, you know, well, who do I call to get that? Like, I don't, you know what I mean? It's just how the chain of command is kind of skewed. And it's just, there's a lot of things that aren't consistent overall. And I think the more we can have it consistent, the better off that it will be for the people that are struggling, the people that are helping them. And I just think that, you know, we should be doing everything we can to set people up for success in recovery. So that ends my little spiel. And I just want to say thank you for Nicole and Amanda for asking Corey and I to speak tonight. It's been such an honor, and I'm so glad that I was able to help in any way. So I'll hand it off.
Thank you, Ellen. It is an honor to be here, privilege. Hi, everyone. My name is Corey Arsenault, 38. I'm a little French community, Prince Edward Island. Today I'm able to identify as a grateful addict or alcoholic. In my experience, that led me to where and who I am today. Our programs teach us so many life skills and practices that can help us with every situation we have to face in life. The pain that addiction caused me and my family, it forced me to seek a new way of life. Today I can honestly say that I have a life worth living. Not to say that it's gotten any easier, but I had the tools and the people in place that could help me manage it a lot better. The biggest thing with addiction I find and mental health that kept me sick was the stigma around it. Felt like, how am I supposed to believe that I can do better if society labels me as a drug addict or a bad person? The guilt and shame labels only add to the harm. We're failing each other as a whole. I'm grateful to be able to be a part of this project, however, to help try and make some positive shifts and lead each other in the right direction. Known way too many people that gave up on themselves, feeling that everyone else had given up on them. I felt that way myself. Met a lot of people in my journey that has struggled tremendously. None of them I found were bad people. They all have huge hearts, same as anyone else. We don't use because we don't care. I found it's more that we care too much, and our feelings can get overwhelmed easily. Need to learn how to love our neighbors again, to stop judging and disconnecting each other, and start understanding where we're coming from, love and compassion, which brings us together in unity. Personally, myself, I found hope in the 12-step programs. I've seen success in those rooms. I felt accepted and understood. I always feel better after going to a meeting or just even meeting with someone for a discussion or to hang out. Our addiction loves to isolate us. I had to learn a whole new way of life and needed each step to be guided by someone who cared more about me than I could care for myself at the time. But I know today that recovery is available to us all. I think we can afford to be working more towards finding the right balance with professionals and peer support to build a stronger community and support system. For me, I needed to learn how to feel my feelings, and sometimes professionals were quick, I found, to hand out medication that would numb those feelings, preventing me from being able to evaluate properly, like what areas in my life that needed to be attended to, preventing me to get to the root of the problem. My journey with addiction behaviors was started at a young age. I was shy and wanted to feel like I fit in, be more comfortable in my own skin, and alcohol did that well for me. It gradually got worse though. Did my first trip to detox. It was 2006. I was 23 years old. Wasn't ready to admit that I had a problem. I did 3-week program with community mental health. I remember being full of fear, and I didn't like the whole recovery thing. I didn't think it was for me. So it was the next 7 years, even after my first son was born, shortly after my trip to detox. Things kept getting worse. My relationship was in the dumps. The business that I had worked so hard on my own to build up pretty much was shot. Everything I cared for got less and less important as my addiction got worse. I just needed to not feel that shame of being that person, that partner, that father, that son, that friend, that member of society that I was created to be. In 2014, I tried another stint at recovery again. This time I knew my life had gotten unmanageable. I did a 2-week detox. It was followed by a 21-day program, and relapsed afterwards while waiting for a bed in extended care home. This happened probably several times where I'd end up without support I needed and back on the streets to wait for a bed for further treatment, relapsing and then having to start over in hopes that things would be different this time around. Poor family didn't know what to do with me, and I didn't know how to stay sober. The hopelessness and shame got worse. To the point of desperation, I ended up committing a crime that costed me a 23-month sentence in provincial jail just after having my second child. But then I was ready once again for a new beginning. I spent a full year in jail and felt like I didn't make any progress. I felt just the same, if not worse, than when I went in. Treatment was lacking in jail. I had the desire to seek a new lifestyle. The resources were limited. It wasn't long after I got out that I used again. Addiction left untreated will always resurface again. Few more failed attempts after led me to get funded to go off island treatment, where I was more able to stay focused on what I needed to do for my recovery, not as much distractions. Most activities were mandatory. We did them all as group. Most of the staff were people with lived experience, more the evening staff. So there was a good mixture of people with lived experience and professionals. There wasn't much time for the atmosphere to not be like recovery atmosphere. Old habits can be broken if we practice new ways. Only problem is I didn't know what way and how to go about it until it was shown to me by professionals or a sponsor and a home group, people that's been there before and found their way out, and they're willing to show us the step-by-step recovery process. We have to accept where we are in our journey. Everyone I meet has different needs, circumstances, and learning skills. Some of the things I've gone through, I wouldn't wish upon anyone, but at the same time, they're the things that help keep me focused and motivated the most. So relapse for me was a huge learning lesson. I had to learn how to guide my thoughts, challenge my old belief systems, practice new ways that are less threatening to my recovery. I learned that I have a lot more to work on daily than just to stop drinking and drugging. I need to grow and maintain a healthy balance in all the three main areas in life: the body, mind, and spirit. All three can affect the way that we think. When we think better, we feel better. We can't think ourselves in the right feeling, but we can action ourselves into right thinking. I could only achieve this in unity and fellowship with a combination of the professionals and people with lived experience that helped me in all different areas affecting the way that I felt. Feel that we all have special gifts to offer to one another, and those gifts are freely given to us to help guide and help each other. Just wanted to say a special thank you to everyone who's impacted me in my recovery, and for all the staff and everyone behind the scenes, that together that we can make a difference. Thanks again.
Good evening, everyone. My name is Susan Silva, and it's a pleasure to be here with you tonight. I'm going to share a little bit from my experience, both as a professional and a person living with a substance use disorder, as well as talk about stigma. The reason I'm talking about stigma is because it is a barrier to treatment. It certainly was for me. So a little bit about my work history. I'm a registered nurse, and I also have my certification in psychiatric mental health nursing. I've worked for many years in an inpatient acute care psychiatric unit at our major hospital here in Prince Edward Island. I've also worked as a mental health nurse with a seniors outreach team and an adult outreach team, and currently I'm supervisor of addictions for Eastern PEI. And a little bit about my history of addiction. I am an alcoholic. I knew for probably 20 plus years prior to getting sober that I was. I actively tried to get sober on my own for approximately 10 to 15 years. I was admitted to inpatient psychiatric unit a couple of times at a different hospital from where I was working. I had counseling. I also met with a psychiatrist numerous times, and eventually I was sent out of province for treatment. I can certainly relate to much of what Ellen and Corey have said. We have many similarities. However, I'm not going to go too much into my story. Thankfully, I've been sober for over 10 years now. I can say from my experience that addiction is a great remover. For me, it took away family, friends, money, self-worth, moral, and my values. So what is stigma? Stigma is any attitude, belief, or behavior that discriminates against people. According to a 2018 article in the International Journal of Drug Policy, wider support of life-saving interventions are more likely to occur when language is shifted to more accurately reflect the nature of the health condition. So changing the language that we use is a major step in reducing stigma. I found it quite interesting when I read this article to learn that a person's treatment plan can be dependent on the language used to describe them when they present for help. International studies by the World Health Organization show hazardous alcohol and drug use disorders are among the most common stigmatized conditions. This is a sad reality that prevents individuals from seeking treatment and keeps them sick. Writing this and preparing for this presentation, it's really led me to reflect on myself both personally and professionally. Do I contribute to stigma? Do I judge? I know I have at times. I know I've had times where the same person comes through the door over and over, and I've probably judged. Maybe some days when I'm not having a good day, I might have thought my problems are worse than theirs. We need to reflect when we realize we are doing this and determine why. I think I'm getting better, but I can catch myself using words that are inappropriate. We always need to be mindful of our nonverbals as well. For me, I find I need to talk with colleagues and debrief when I find I may be feeling judgmental towards somebody. And it's also important to speak up if I see or hear others using derogatory language or being judgmental. When we judge and label others, it may feel and seem harmless. However, it is not. There are significant consequences to the individual that experiences stigmatization. As you can tell, even in this presentation, I'm struggling with appropriate language. All of my life and career, I've heard and used certain lingo when talking about people with substance use disorders. And making the shift is taking effort, and part of that is also being aware. Words matter. Language can be used to promote or decrease stigma. Therefore, we need to choose our words wisely. We need to use person-first language. This recognizes that people are people first. The focus needs to be put on the individual first, not the diagnosis. And I know for myself, and I this really came to light when I was preparing for this, and realizing that I had a problem with alcohol. I had a really hard time saying that I was an alcoholic and coming to terms with the fact that I was an alcoholic. It just felt really dirty to me, that word. I always compared it to the worst swear word that I can think of, and I wouldn't share that with you guys. And I think this prevented me from admitting and accepting that I had a problem with alcohol, and it prevented me from seeking help for quite some time. I struggled to say or admit that I was an alcoholic. The impact from this one word was profound. Perhaps if the term substance use dependence was used, I might have sought treatment earlier. I'm not sure, but I might have. Words from healthcare professionals, media, such as the news and movies, and various professionals are typically negative with regards to substance misuse. And these terms have been normalized. When I've been referred to as an alcoholic by other alcoholics, I've never felt judged. However, hearing it from a professional carries a sting to it. Is this because they're in a role of authority or because they haven't been through it themselves? I'm not sure. I think as professionals, we need to use appropriate language. However, it is up to the individual with a substance use disorder to refer to themselves as they wish. I think the reason I don't mind another alcoholic referring to me as an alcoholic is because I consider them my peers. For me, these peers are the people that have helped me the most in staying sober. I have always felt understood and never judged by my peers in recovery. I became heavily involved in AA when I first got sober and still attend today due to the warmth, support, and understanding that I have felt in those rooms. I've been to meetings in many provinces, and in every one I've walked into, I felt at home and among family. For me, peer support is invaluable. I think this is mainly because I feel understood and not judged. There is no stigma. This is what still helps to keep me sober today. With person first language, we have to recognize the person first and not the illness. When I meet people, I don't identify as an alcoholic. I'm Susan. Typically, the only time I identify myself as an alcoholic is when I'm in an AA meeting, or if it can benefit someone else, such as a family member or a friend who thinks they may have a problem with substances. I'm not ashamed anymore, however. Being an alcoholic or a person with a substance use disorder does not define me. According to the Government of Canada, there are 3 types of stigma. The first is self-stigma, and this is when the person internalizes negative messages about people who use drugs and alcohol and apply them to themselves, causing low self-esteem and shame. This can cause the individual to hide their usage and not seek treatment. The second kind is social stigma. This is negative attitudes or behaviors towards people who use or towards their friends or families. Talk of addiction like it is a choice. Negative labels. This can lead to self-stigma. There is considerable shame and guilt with addiction, and individuals are very sensitive and fragile. Our language and judgments can be and are very detrimental. The third is structural stigma. When people are not taken seriously, this is when people are not taken seriously, workplace policies that cause individuals to hide their usage, not providing service until someone has hit bottom, or providing a lower quality of care. All 3 types of stigma are a barrier and lead an individual not to seek treatment early or at all. Fear of stigma is what kept me from seeking treatment. My biggest fear was being judged by my coworkers when I was working in a mental health setting. Having said this, much of my fear of stigma was unfounded. When I did finally seek help, I was accepted and supported by those around me. Substance use disorder versus abuser and addict. We are not bad people trying to be good. We are sick people trying to be well. I remember hearing this in a meeting, and it was a pivotal moment for me. I thought I was a terrible person due to the terrible things I was doing because of my addiction. And when I heard this, I realized I was not a terrible person. I was just sick. We need to educate society about this, especially individuals who work with individuals with substance use disorder. Substance use disorder is a disease, not a moral weakness. It is chronic and progressive, so we should not judge when a person presents for help numerous times. I often catch myself using dated language and need to work on being more aware. It's a difficult shift when you've grown up using certain terminology. I personally am okay with labels now that I have as much recovery as I do, but for individuals contemplating treatment or new to it, it can be very harmful. It will take time to make a shift in the language we use. We are seeing such shifts more often now. I know, being the age that I am, older than probably a lot of you out there, I've seen a lot of words that we would have used in the past change because they're considered derogatory. So it is possible to make these shifts. Labels and language lead to further feelings of being judged. So how can we change the language that we use? We can all learn to change the language, and that's a first step in the beginning of ending stigma. So instead of calling somebody an abuser or an addict, we can say they're a person with a substance use disorder. Instead of referring to them as a former addict, we can say they are a person in recovery. Instead of saying drug habit, we can say regular substance use. Instead of using the terms positive and negative drug screens, instead of saying clean and dirty drug screens, we can now use terms such as positive or negative. The American Psychiatric Association has dropped the term abuse from its diagnostic terminology. Therefore, this term provides no advantage in terms of clinical precision or public health communication. I was impressed by that. I thought it was a great first step in changing our language. So how can we reduce stigma? Education is key in reducing stigma. People often stigmatize others due to fear and lack of knowledge. We need to be aware of our attitudes and behavior, take time to reflect on our words and judgments. We need to educate others and be a positive role model, pass on positive attitudes and challenge stereotypes. We need to be supportive of those seeking treatment, and we need to use person-first language. I know I have a caseload of clients, and anytime somebody new walks through the door for the first time, I always commend them for seeking treatment. It takes tremendous courage for them to ask for help. And I know personally, fear of judgment and shame and stigma is what kept me sick for years. And I know this is true for others as well. And until I prepared for this, I did not really realize the impact of my words. And looking at my own experience, that one word, alcoholic, it was profound. And it was certainly an eye-opener for me. I often wonder how my words are impacting other people, either positively or negatively. So we need to do better with our language that we use, and we can do better. Thank you.
Hi, everyone. Thank you for listening so attentively to us as we continue to just move in and out here. My name is Nicole Peters-Buzo, and I have 20 years of clinical experience working in mental health and addictions in PEI as a registered nurse and more recently as a researcher. I'd like to start by extending a huge thank you to Ellen, Corey, and Susan for sharing their lived experiences with us and the experiences of their peers. Their experiential knowledge is really invaluable to us. And it's so important to have those stories heard. I'll now share with you some research done in relation to substance use and barriers in PEI that people who use substances face, particularly in accessing and receiving treatment services. This echoes a lot of what Ellen, Corey, and Susan have already shared. And so this slide highlights some of the recent empirical research. In 2020, Opioid Replacement Therapy Initiatives Project was funded through Health Canada's Emergency Treatment Fund. It was the ORT client survey that we used, gathered qualitative and quantitative data and identified key barriers, including transportation, stigma, and medication costs. In 2018, the PEI Department of Health and Wellness did a survey of the take-home naloxone program, and they surveyed 18 participants and found that 72% reported feeling stigmatized as an opioid user. And in 2014, a qualitative exploration study of injecting on the island, looking at the service needs of persons who inject drugs in Prince Edward Island, interviewed 8 individuals who self-identified as injection drug users in PEI. They found reported experiences of stigma, including perceived stigma from healthcare professionals. So the PEI Opioid Replacement Initiatives Project, as I said, was funded through Health Canada's Emergency Treatment Fund, which provided one-time funding to Canadian provinces and territories to address the opioid crisis. PEI's proposed initiatives included implementing a peer support program, providing telehealth capability and mobile service delivery, and recognized the need to include the client voice. And so a proposal was submitted to the Research Ethics Board and received approval to conduct a survey with the clients in the ORT program. And the client survey ran from June of 2020 to September 2020. It was meant to run longer, but because of COVID and some of the restrictions at the time, it was slower getting started. So the client survey, it was a mixed method study. There were 119 participants, which was approximately 12% of all ORT clients on treatment in the province at the time. And it included all the sites that provide ORT in PEI. So we have provincial mental health and addiction sites throughout each of the regions, Queens, Kings, and Prince. And of those sites, there were 80 individuals who participated. We also have a physician-run private clinic in Charlottetown, and there were 32 participants from there. As well, we had 7 participants from the Provincial Correctional Centre at the time who would have been on treatment at one of the other sites, but were incarcerated at the time the study took place. We included nominal and ordinal questions in relation to initiation, how they started using opioids, retention on treatment, and whether there were difficulties in staying in treatment, satisfaction levels, endorsement of new initiatives, including peer support, telehealth, and mobile service delivery, as well as open-ended questions looking at reasons for satisfaction and dissatisfaction with the program, and feedback on the new initiatives. Looking at participant demographics, the participants in the study identified as either male or female, and more than 97% identified as Caucasian or white. Just over 50% of participants were in the 35 to 45 year age group, with the next largest age group being 19 to 30. There was representation from across the province in each of the regions, as I said. And as you can see, 70% of participants resided in Queens region, which includes our capital city of Charlottetown. And this is representative of the ORT population in PEI, as approximately 70% of individuals on the program in PEI receive their treatment in the Queens region. Another question that participants were asked about was how they started using opioids. And as you can see here, 39% reported they had started their use from prescription for pain, and 37% received opioids from a relative, friend, or acquaintance. Another 18% said they started using opioids off the street. So we gave them the options to choose, and this is kind of how it played out, which is not that surprising, that a lot of individuals started with prescribed medication or from friends. We also looked at program satisfaction. 82% of survey participants indicated they were either satisfied or very satisfied with ORT overall. Satisfaction levels were found to be significantly associated with the clinic where treatment was accessed, with a p-value of 0.001. The Provincial Correctional Centre had the higher numbers, answering as not satisfied. And somewhat satisfied than would be expected if the satisfaction levels were comparable across clinic sites. Similar analysis was done for medication type and was found that satisfaction levels did not vary by medication type, be it Suboxone or methadone. Following the categorical question related to program satisfaction, respondents were asked to explain why they selected their responses. These were open-ended questions, and then they were analyzed thematically. Participants described 5 main factors that contributed to their satisfaction or dissatisfaction with ORT. These included treatment outcomes, staff characteristics, program quality, accessibility, comorbidity issues, and within each of these broad themes were more specific sub-themes that emerged. In an attempt to qualify the importance of each of the themes in contributing to program satisfaction among the participants, the number of responses falling within each theme were then calculated and presented here. So the most heavily commented on theme was the treatment outcomes, with 47 comments. And the sub-themes there focused on quality of life, substance use cessation, and symptom management. Many participants credited ORT with saving their life or giving them back a life worth living. 32 comments were related to staff characteristics, and the sub-themes there focused on staff competencies, ability to build rapport and respect and being non-judgmental. The remaining themes included program quality with 20 comments, accessibility, there were 16 comments there, and comorbidities, 13 comments in that order. So treatment retention, it's encouraging, excuse me, it's encouraging that 62% of respondents said they did not find they had difficulty remaining on ORT. However, 35% said they did have difficulties, and a further 2.5% did not answer the question. So this slide here shows the identified reasons for treatment retention difficulties that individuals identified. The participants who identified having difficulties remaining on treatment were asked to check off reasons that applied. 50% of those who had treatment retention difficulties identified transportation as an underlying reason. 29% identified stigma. 27% identified the cost of medication, as well as 27% identified that the treatment did not consider other health or living conditions. So you can see the breakdown there of the number of some of the different factors that played a role in treatment retention. So retention across clinics. Chi-square tests were used to determine whether retention was significantly associated with the clinic site. The proportion of participants who reported having difficulty staying in treatment did differ by clinic site, with a p-value of 0.006. Standardized residual analysis revealed that the Provincial Correctional Centre made the greatest contribution to the chi-square result, with a standardized adjusted residual of 3.6. In fact, all respondents from the Provincial Correctional Centre noted difficulties with staying in treatment. Other sites were pretty comparable in terms of their response distribution for the retention question. Similar analyses were done around medication type, and there was no, it was found not to be significant. So the proportion of participants reporting difficulty staying in treatment was comparable across, again, similar to the satisfaction, comparable across medication types, whether it be Suboxone or methadone. Survey participants were also asked about potential solutions or program enhancements, such as peer support and telehealth. I will share some data in relation to this, and Amanda will share further information during her presentation on virtual solutions. Survey participants were provided with a definition for peer mentorship or peer support. It was defined as having people with lived experience or experience with an opioid addiction trained to support clients on treatment, receiving treatment for opioid addiction, and that it was meant to provide a more client-centered approach to treatment. To assess participant endorsement of peer support, they were asked to select yes or no to the question, do you think peer support would be helpful in PEI? And 79% responded yes, 5% responded no, and 16% did not answer the question. So with that high of a response of a not answer, it could be that they didn't quite understand the definition. But almost 80% responded yes, and from that we had a lot of information, a lot of comments around the peer support piece. There were 110 comments related to the peer support initiative, and of the 110 comments, interpersonal was the most common theme, representing 81% of all comments. Sub-themes under interpersonal were the ability to relate, focusing on trust and respect, and hope and support, particularly in relation to early recovery. I will read you a few of the direct quotes from participants, and you will note that they often referred to themselves as addicts. And we wouldn't use that terminology in referring to them, but I will read out these quotes, which are their direct quotes. So under interpersonal, here's a few things that people had to say. Some of the most meaningful interactions that I've had in treatment have been with staff that are recovering addicts. I think people who have lived with addiction are granted more credit, respect with other addicts on their opinion because they understand it. And it is difficult in the first year to reroute a new life. Having people who have managed to get clean and stay clean would be helpful. Program-specific themes focused on staff, education, and mental health. And a couple of direct quotes there are, having educated staff is great to a point. Having educated peers who are in recovery would be excellent. And it helps when someone knows exactly what you have gone through rather than having people trained to understand what you are going through. The interpersonal theme was around individual choice and privacy, and it was basically people indicated that it should be an individual's choice whether or not they want to have a peer worker. So endorsement of telehealth and mobile service delivery, we did similar. They were provided definitions of mobile treatment service and telehealth. Mobile treatment was defined for the participants as meaning treatment that could be provided in different locations and could involve staff meeting with clients in different locations closer to the client's home. And telehealth was defined as the use of a secure video connection to connect with ORT prescribers, which could make it easier for clients with transportation issues to get treatment. Participants were then asked the question, do you think telehealth and mobile treatment would be helpful in PEI? And just about 84.9% said yes. And again, following the question related to the endorsement of mobile services and telehealth, respondents were asked to explain why they selected their response. And these, again, were open-ended questions that were thematically analyzed and yielded the themes that you see here. So under the theme accessibility, there were 65 individual comments, 39 of which, or 60%, fell within the sub-theme of transportation, including transportation difficulties from rural locations. Other sub-themes that emerged under accessibility were related to finances and scheduling appointments around work, school, or childcare. There were 12 program-specific comments, and you can see there the sub-themes mostly around the program were comprehensive care, consistency and flexibility, comfort and convenience. Interpersonal, again, looking at stigma and judgment and support, and intrapersonal shame and privacy. So this concludes the research portion of the presentation regarding the barriers that we have found, both through the lived experience piece and through some of this other research. I'll now turn it over to Amanda to discuss the virtual initiatives.
Great, thank you, Nicole. So we've heard from 4 presenters who've touched on barriers to accessing help, and now we're going to switch gears a little bit and talk about solutions with a focus on virtual innovations. We know that virtual solutions in healthcare are in demand now more than ever. This is due in part to a need to address challenges of the pandemic, but it's also due to developments in technology and to new models of healthcare that strive to meet client needs in more versatile ways. There are a number of objectives when it comes to using virtual solutions. So these technologies help provide accessible and timely care. They can reduce or remove barriers like transportation issues, scheduling issues, geographical barriers, and conflicting commitments such as caregiving or work. These solutions can also address concerns around privacy, anonymity, and stigma regarding mental health and substance use issues. And by addressing these concerns, we tend to see increased program recruitment and retention when we offer virtual options to clients. Another positive is the provision of services and supports to rural or underserviced areas, which may not have broad access to in-person programs. And in the context of COVID-19, these solutions have enabled initiation and continuation of care while facilitating social distancing and reducing the risk of disease transmission. So we'll talk a little about telehealth in addiction services. We know that telehealth is meant to enhance traditional care rather than replace it. It can extend provider availability while in many cases offering an immediate resource to clients. It's useful for patients for whom face-to-face access is limited, such as patients residing in rural areas. And it can also increase service access for patients with concurrent disorders who may need access to diverse services or care providers at once. When we look at patient satisfaction results, we tend to see no difference in patient satisfaction for care that's provided through telehealth versus care that's provided in person. And I will also highlight CRISM guidelines for telemedicine support in addiction services during COVID-19. These recommendations and guidelines were developed with representatives from across the country, including researchers, physicians, and people with lived experience. In PEI, plans are in place to expand service delivery within our opioid replacement therapy program through telehealth, as Nicole mentioned. So the map shown here reflects the current state in PEI, where the red dots show where primary care centers are located, and green dots show where ORT clinics are located. Our proposed method for expanding the program through telehealth will be to have ORT clinics operating at primary healthcare centers where clients can be connected with ORT prescribers by telehealth. And in this way, telehealth will make ORT more accessible, more available closer to clients' residences, and will address some of the barriers that were identified in Nicole's presentation. And we also use telehealth and PEI for psychiatric services. So telepsychiatry has been available in PEI prior to the pandemic. Patient and provider documents had already been developed and best practice guidelines had been identified and implemented. With the onset of the pandemic, telepsychiatry services were expanded quickly in both outpatient and acute settings. Some examples of acute settings were a temporary urgent care clinic, as well as the 2 major emergency departments on the island. And the rapid expansion of telepsychiatry services was facilitated by already having guidelines and the appropriate technology in place. So some of the outcomes of expanded telepsychiatry during the pandemic were reduced wait times for psychiatric assessment. We also observed high levels of patient satisfaction for virtual psychiatry services. And these outcomes are relevant for patients experiencing addictions issues, as we know that comorbidity of mental health and substance abuse issues is very common. And in fact, our Health PI administrative data indicates that 1 in 3 clients who are receiving psychiatric assessment have accessed Health PI's addiction services. Therefore, these outcomes reflect enhanced access and quality of service for this population. So I'll provide a little more detail around our outcomes. We've seen a steady decline in wait times for psychiatric consults since the start of 2020. Median wait times were almost 100 days in the winter of 2020, and they reached a low of 17 days in the fall of 2020. Currently, wait times for the initial psychiatric consult are about 28 days from the time of referral to the time of first consult. And although I don't have the number of telepsychiatry consults plotted here on this figure, I believe that we'd see an inverse relation, where as the number of telepsychiatry appointments increased, we see a decrease in the wait times for psychiatric consult. Telepsychiatry has enabled recruitment of psychiatrists from off-island, and it's also led to greater flexibility and efficiency for in-province psychiatrists. So now we'll look at the right side of the screen and at some satisfaction survey results. So we surveyed 28 clients who had psychiatry appointments. 17 of these participated in a telepsychiatry appointment. And of those 17 patients, 100% indicated that they were satisfied or very satisfied with the virtual interaction, which replicates the satisfaction results that we cited for telehealth and addiction services on the earlier slide. Another virtual initiative worth noting is PEI's online mental health and addictions platform, Bridge the Gap, which was launched in December of 2020. And Bridge the Gap acts as an online home where users can browse mental health and substance use resources and select what best meets their needs. The site includes a comprehensive service directory, psychoeducational resources, activities focused on being creative and sharing experiences with their peers, and online evidence-based programming. So if we move to the next slide, here we have a screenshot of some of the programs available through Bridge the Gap. There's a link to a federal platform called Wellness Together Canada, where users can find additional programs and supports. And there are also links to enroll in several programs with our partner organization, the Strongest Families Institute. Strongest Families offers programs to address anxiety and behavioral issues in children and youth, and they now also offer online programming for adults who are experiencing anxiety. All of the Strongest Families programs are evidence-based. They're supported through phone sessions with a coach and are available by distance, with content being presented on an online platform or with a hard copy manual, depending on clients' preferences. So here we'll look at some of the service evaluation outcomes. For PEI residents participating in the program, there has been over an 80% outcome success rate of resolving the primary presenting issue. We also see low attrition, high client satisfaction, and results have been found to generalize to other domains such as academic achievement and parental mood. And although these programs are not specific to substance use, we know that many clients experience concurrent issues. So individuals experiencing substance use, along with mental health concerns or with family issues, may find help through these programs. Another online intervention currently being offered to eligible participants is Tranquility, which is an internet-based cognitive behavioral therapy program. Tranquility offers programs for anxiety, programs for depression, and because 60% of people with anxiety or depression experience symptoms of both, Tranquility developed the first adaptable comorbid program offered as internet-based CBT. Tranquility offers flexible coaching, and clients can choose to connect with their coach through video calls, phone calls, or in-app messaging. In line with the stepped care model, clients can choose to take part in a self-directed way or with the assistance of a coach. In terms of the evidence base, we see significant drops in depression and anxiety scores on the DAS-21 after program completion. And these improvements have been observed in different populations, including the general public, military families, and most recently, these outcomes are being investigated in parents who are receiving the program as part of a CIHR-funded study. Health PEI is currently partnering with researchers at Dalhousie, UNB, and Nova Scotia Health on a CIHR-funded project to implement and evaluate Tranquility for parents who are struggling with anxiety and depression during the pandemic. And recruitment in PEI is ongoing for this project. So the study will aim to investigate parents' preference for level of ICBT, whether it's guided, minimally guided, or self-directed, and modality of guidance, be it phone, in-app messaging, or through video chat. We will also analyze whether level of service delivery predicts outcomes, and we will determine which parental stressors are most common and which stressors are most closely associated with intervention outcomes. We also plan to extend outcomes to include alcohol use, since 36% of parents with dependent children have been found to increase their alcohol use during the pandemic, according to Mental Health Research Canada. And further survey data by the Centre for Substance Use and Addiction show that changes in alcohol use during the pandemic are largely associated with increases in stress and anxiety. So the next eHealth tool I'll discuss is the JoyPop app, which was developed by Dr. Chris Weckerly at McMaster University. And just to give an overview, JoyPop is a smartphone app designed to promote resilience in youth through the use of daily emotion regulation and cognitive organization skills. It's built on the principle that we all have innate resilience and that there are strategies we can apply to help harness this resilience. It's informed by current neuroscience on brain plasticity and stress responses, and it taps into neurocognitive skills that are known to be important for resilience. So there are a number of different features of the app, including a calendar, a journal, circle of trust, in-app access to youth-specific helplines, mood ratings, and other activities. The mood ratings serve to make users more aware of their moods, and this feature acknowledges that to effectively regulate our emotions, we must first understand our emotions. App users receive suggestions for activities to engage in based on their dominant mood. Other activities available through the app include breathing exercises, artwork, a sleep aid function, and a square moves game, which helps to prevent negative thoughts by promoting a state of flow and providing sensory motor distraction. And in terms of the evidence for the JoyPop app, a recent study published by McIsaac et al. Examined the efficacy of the app in first-year undergraduate students. And there was a subsample of these students who reported childhood adversity. Students used the app for 4 weeks, and changes in resilience, emotion regulation, executive functions, and depression were assessed at 2 weeks and 4 weeks following initiation of the app. App use was associated with significant improvements in emotion regulation and reductions in depressive symptoms. And an interaction was found between adverse childhood experiences and days of app use, such that participants who reported the most adversity showed the most rapid improvements in emotion regulation. And in PEI, Health PEI is launching a pilot study that will aim to replicate and expand on the McIsaac et al. Study. So participants will be youth in mental health and addiction services who will be receiving access to the app as an add-on to services. And as in the McIsaac et al. Study, we will examine changes in emotion regulation, resilience, and depression at 2 and 4 weeks after beginning daily app use. We will also examine changes in measures of substance use and alcohol use at these time points. There is a large body of research to indicate that alcohol and other substances are often used as a means of regulating emotions. Yet no study to date has examined substance use outcomes in youth using the JoyPop app. Given the documented changes in emotion regulation that have been found to correspond with daily app use, we anticipate that changes in emotion regulation will be accompanied by improvements in alcohol use and substance use outcomes among youth. We will also examine satisfaction, engagement, and retention data to assess the feasibility of this app as an add-on to services for youth. And the last eHealth program I will be discussing is called Breaking Free. Health PEI signed an agreement allowing for up to 500 clients in our addiction services to gain access to this online program. So what is Breaking Free? It's an evidence-based program. It's described as a digital behavior change program for substance use disorders. It is interactive, engaging, and personalized to each client. For instance, each client identifies their own recovery goals and monitors progress towards those goals. And goals might include abstinence for some individuals. For others, it may be less risky use or less frequent use. They can also have goals related to well-being or to mental health. Breaking Free combines CBT with mindfulness, relapse prevention, motivational techniques, harm reduction, and other proven approaches in the treatment of substance use disorders. Breaking Free can be completed in a self-directed manner or can act as computer-assisted therapy, where clinicians and care providers use the program as a supplement to counseling or group programming. And in PEI, we're pursuing that second and third option, where we're enabling individuals who are already accessing addiction services to receive Breaking Free as an additional support. The clinical effectiveness of the program has been evidenced by research, and research on Breaking Free has appeared in over 33 peer-reviewed publications. Using Breaking Free has been found to lead to reductions in drug and alcohol use, reduced substance dependence, improved mental health and social functioning, and improved recovery progression. More specifically, clients who complete the program are 60% less likely to re-present to services within 1 year. Breaking Free is also partnering with the University of Toronto, Centre for Addiction and Mental Health, and Community Addictions Peer Support Association on a CI chair-funded study that will examine how Breaking Free can be used alongside peer supports to influence outcomes in both the client and the peer supporter. We don't currently have PEI-specific data as we're quite early in the pilot of Breaking Free, but we do plan to monitor and report on outcomes. So that concludes our overview of the telehealth and virtual programs being pursued by mental health and addictions. I hope we've illustrated how these virtual solutions can help address some of the barriers that have been brought forward in this evening's presentations. However, we recognize that virtual solutions are only a piece of the puzzle and that there continue to be barriers to care and unmet needs in addiction services. For our discussion, we will introduce some of these and then we'll invite opportunities for input and discussion. So we discussed how e-health can help overcome stigma as a barrier to care by providing individuals with a more private manner of seeking help. However, virtual solutions don't get to the root of stigma, which is a lack of understanding and a need for education among the public and in some cases among healthcare providers. Some of our current strategies for addressing this include new educational opportunities for staff in the area of trauma-informed care, recovery-oriented care, person-centered care. And because we know words can hurt or words can help heal, we're also putting a lot of emphasis on person-first language. Health PEI has also expanded their communications team, and mental health and addictions will work closely with this team to engage the public so that we can promote an understanding of mental health and addictions issues. We want to increase awareness of services and supports that are available to Islanders, and we want to start to tell patient stories in ways that really emphasize hope and recovery. And when I talk about engaging to share information about our services and supports, that also gets to some of the barriers that Ellen discussed around lack of clarity around processes or reasons behind treatment decisions. So definitely a need for public engagement and communication. We've also identified a need to engage and consult with people with lived experiences in a sustainable way. I think in this project, we knew prior to this project, but this project has really emphasized the importance of engaging with people with lived experience and learning from their experiences and their stories. So we need to continue to do that. Peer supports will be integrated as part of addiction service delivery, and this will be happening over the coming months. We know that peer support workers bring an expertise that professional treatment alone cannot replicate, and peer supports are highly valued by people who access that form of support. We've also noted how virtual solutions can promote accessible and timely treatment, yet there will always be some services that are necessarily delivered in person. And one notable concern is access to inpatient withdrawal management beds. So some strategies being pursued to address this need include expanding outpatient withdrawal management services and expanding outpatient induction for opioid replacement therapy. This in turn will free up beds for the most appropriate cases, for urgent cases or complicated cases who really need that inpatient level of care, which will improve access to these essential services. Telehealth may enable this initiative by equipping our outpatient services with physician support and prescriber support where that may not readily be available in person or on site. And Health PEI is also adding 4 beds east and west for inpatient withdrawal management as part of master planning, so system renewal within mental health and addictions. This will decentralize services and promote access to inpatient withdrawal management across the province closer to Islanders' homes.
So Amanda mentioned that the master plan, which involves mental health and addictions redevelopment project, and in response to clear community need, the Department of Health and Wellness in partnership with Health PEI has been engaged in various review and planning initiatives for mental health and addictions across the province. Increasing access to mental health and addiction services and programming through community first approach is a crucial pillar to the current government's commitment to improving healthcare. This slide just shows a picture of the new being developed, currently in development, in building construction of the new women's residential housing, which will increase space for women and new programming for women in recovery. And at the bottom of the slide, you can see the link if you would like to check out more about and follow the progress of the redevelopment project for mental health and addictions at PEI. With that, I think we will move into the discussion.